They told you it's burnout. They lied. It's nurse trauma. Your body never lied. The system did. I'm Dr. Lori Laws. Let's heal the real root cause. One of my favorite parts of the day is reading and responding to your emails. This week, my inbox was overflowing. So I brewed a fresh cup of tea, played some relaxing music, and I read each message. And I kept coming back to Simone's message. Simone is an emergency department nurse in Florida, and she's worked there for nearly 25 years. She has a perfect track record, 0 occurrences, 0 verbal or written warnings, and glowing performance reviews every single year. Until she started questioning unsafe patient assignments. Simone didn't yell. She didn't threaten anyone. She simply questioned potentially dangerous staffing decisions, and she verbalized her concerns professionally and clearly. She questioned assignments that stretched her past safe capacity. She pushed back on the non-nursing work that was being transferred to the nursing staff without removing anything from the existing workload. Now, if you've been following along since episode 85, you recognize this. It's force 2, stretched beyond the breaking point. Simone was not failing that force. She was pointing directly at it. And that is apparently the most dangerous thing an experienced nurse can do. Stay with me because we're going to follow the money. One day, leadership sent Simone a text at home on her day off. They wanted to meet to discuss something that had happened the week prior. Simone pressed for context so she could prepare for the meeting. They gave her none. Simone sat with that uncertainty for 4 days. During the meeting, they told her she had a communication problem. When Simone pressed for details, their response was, and I am quoting directly, "Well, we can't go into specifics." Simone asked the only reasonable question she could. Then how can I correct something if I don't know what it is? And instead of an answer, they handed her a template. They told her to write her own performance improvement plan to help her improve her communication, while their own communication was vague and condescending. Simone would need to complete the PIP, which is what Performance Improvement Plan, the acronym for that, for those of you who are unfamiliar. She was told she would need to complete the PIP on her days off. It was due when she returned to work 3 days later. There would be no pay, no guidance, and no specific incident for her to address. There was no date and there was no witness. Just a blank template with some written instructions and the expectation that she would fill it out and hand it back. Now, Simone has no background in education. She doesn't have any training in the legal or HR implications of a PIP. She's a seasoned clinician, among the best on her unit, who is now having to conduct research in an area that was out of her expertise for an unspecified communication incident. It took her 3 days that she will never get back, 3 days unpaid, to work through a process that she never should have been assigned in the first place. She's not a writer, and the last 12-page document she prepared was in nursing school over 25 years ago. She had to ask a family member for help, and then she had to lean into AI because the template was that poorly constructed and so very cumbersome. This was all, again, completed in her own time on her own dime. Over 15 hours of labor stolen. Wage theft via the carrot and stick coercive leadership model. The entire time, she said, she felt like she was doing leadership's job, and she was. I like to call this situation the $354,578 PIP. Simone is 7 years from full retirement, given that settings policies. She's at the top of her pay scale and no longer eligible for merit raises. Cost of living adjustments are all that remain, and she earns roughly $22 more per hour than a new graduate or early career nurse. In wages alone, that differential is $319,760 over the next 7 years. And that doesn't account for benefits. Hospitals spend around 28 to 32 cents in benefits for every dollar in wages, depending on the system. So we'll use the midpoint of 30 cents. The total 7-year cost differential between keeping Simone as a very experienced nurse or replacing her with a new graduate nurse climbs to $415,688. That figure covers wages and benefits only. It doesn't include pension or retirement contributions because, well, those vary by setting. Now, let's consider the other side of that ledger sheet. According to the 2025 NSI National Healthcare Retention and RN Staffing Report, the average cost to replace one staff nurse is $61,110. So the hospital will save a net $354,578 by forcing Simone out of her role. They don't have grounds to fire her, so they're manufacturing them, and they're making work conditions so unpleasant and unfair that Simone, they expect, will just leave, as so many experienced nurses have done before her. The hospital does not have a communication problem with Simone. It has a budget problem, and Simone is a line item expense that they are trying to eliminate. This is not conjecture. Experienced later career nurses like Simone are experiencing this corporate pruning nationwide. It's well documented in the peer-reviewed literature. Researchers at University of Pennsylvania School of Nursing published a study in July of 2024. They found that hospitals across the country are actively reducing the proportion of experienced registered nurses on a staff as a cost-cutting measure. The institutional term for this, they call it skill mix optimization. Fewer experienced nurses, more cost-effective early career nurses in their place. And what does that cost the patients? Well, it's a 10 percentage point reduction in the experienced RN's share of total nursing staff. When that happens, it's associated with a 7% higher odds of in-hospital death. The researchers projected 10,947 avoidable patient deaths annually as a result of this model. What does it save the hospital? Well, for starters, $31.94 per patient per day in labor costs. Now, if we think about a 300-bed urban hospital that is running at just average occupancy, that is $2.4 million per year moved from the expense column into the profit column. The hospitals have access to this research. I found it. Surely they can. They know these numbers, and they're choosing the $2.4 million profit while their patients are forced to gamble with their lives. As I described in episode 88, experienced nurses are not dangerous to patients. They're dangerous to the hospital's budget. The ones who advocate, the ones who question, the ones who have been at the bedside long enough to know exactly what is being done and why. Those are the ones the system moves to eliminate. Now, before I continue, I want to tell you about the Nervous System Reset. This is a live 3 half-day immersive event built specifically for nurses, and it's the only one of its kind. This is not a webinar. It's not a recorded course. It is a live, structured healing experience built on the science of how nurse trauma forms and how it heals. This event will sell out, so if you want to be among the first to know when registration opens, I'd get over to that wait list right now at drlorilaws.com reset. And we'll drop that note and we'll drop that link in the show notes. Simone's story is not an outlier. In February 2026, Mission Hospital in North Carolina fired nurse Molly Zenker after she advocated for improved telemetry staffing and suggested that safety concerns might need to go public. A state senator tracking the situation stated on record that they have seen retaliatory firings every single time the federal and state government show up there. In May of 2025, St. Vincent Hospital in Massachusetts fired nurse Carla LeBlanc after she spoke on a podcast about dangerous staffing conditions. She filed a whistleblower lawsuit, and the case is now on record in Worcester Superior Court. In case after case, the allegation against the nurse is identical: communication, attitude, professionalism, not a good culture fit. Rarely is there a direct incident, a date, a witness, or any evidence submitted. Just a deliberately vague allegation and a paper trail constructed to go exactly where they need it to go. HR professionals and nurses alike have said this publicly on many professional platforms. The PIP has become the paper trail of the soon-to-be exit, an exit that the employee does not want and for which they are being unjustly accused. It is constructed after the decision to terminate has already been made. The allegation is kept vague by design. A specific allegation can be challenged. A vague one is nearly impossible to contest. This pattern is so widely recognized that it circulates openly on LinkedIn, discussed by HR professionals and clinical nurses in the same threads. It has never formally been studied in nursing populations, but that study should exist. I would conduct it myself if I had not just retired from academic research. So to my fellow nurse scientists, this is a study that needs to be done. Simone is not being managed out of poor performance. She is being pruned with surgical precision that can be accounted for to the penny on a spreadsheet. And the system has been doing this long enough that it no longer needs to hide it anywhere but inside a fictitious PIP. The system has a contingency for almost everything. It has a contingency for the nurse who advocates. It has a contingency for the nurse who questions, who pushes back, who files the report. It has a paper trail ready for the nurse who will not go quietly. What it does not have a contingency for is the nurse who heals. A nurse running on a regulated nervous system can see the chessboard. They can not be destabilized by a vague PIP with no incident, no date, no witness. They cannot be convinced that the problem is their communication style when they know the problem is a $415,000 line item on the hospital's expense report. That is not a nurse that the system can manage. And that's exactly what the Nervous System Reset live event is designed to address. In this 3 half-day immersive event, I will be with you every step of the way. It is the first time I am bringing the nurse-specific trauma healing framework to nurses in real time in an immersive format. Not a webinar or recorded course, a live, structured, held healing experience built on the science of how nurse trauma forms and how it heals by the nurse scientist who did some of the research and wrote the book and founded the nonprofit and is here with you every step of the way. This event will sell out. Join the wait list to be the first to know when registration opens. The link is in the show notes, or you can visit it at drlorilaws.com reset. I will update you on Simone's situation as new information emerges. She's currently navigating the PIP process. And I'll leave you with a question that's been on my mind, and perhaps it's on yours. What parts of Simone's story are you seeing or experiencing in your own workplace right now? Find me on social media or send me an email. I read and respond to every message personally. All that information is on my website at drlorilaws.com. If this episode resonates with you, I'd appreciate it if you would share it with a nurse who needs to hear it. Leave a review for me on your favorite podcast outlet, because this is how we reach the nurses who still don't know the truth about what is being done to them. From my healer's heart to yours, and until next time, namaste.